Hello, thank you for tuning into this webinar. I hope you'll find it valuable and insightful. My name is Sophie Lindwald and I work for BES Healthcare, and I've been organizing the Do No Harm, Know Your Power webinars. Before playing through the webinar, I thought I'd take a moment of your time to briefly explain our campaign, Do No Harm, Know Your Power. The campaign is inspired by changes we've seen in the healthcare system due to time pressures and financial demands, which has led clinicians to make clinical decisions that don't always lead to the best outcome for the client. These challenges have adversely affected patients, leading to an increase in harm. To change this, to do no harm, we want to empower clinicians to say no to equipment that has not been tested to its appropriate standard and give them the power to bring clinical recommendation back into the buying process and make right decisions for the best possible clinical outcome. BES works with various bodies, charities, and industry experts to make information on standards, equipment, and best practice guidelines accessible to you. We also offer free training where needed. These webinars might not change the industry overnight. Still, we feel that they are the beginning of a movement to inspire clinicians, manufacturers, and end users to look for alternative solutions that fit best clinical practice. That was my moment. Thank you for listening and enjoy the webinar. So hello everyone, and welcome to our part 2 of our Pressure Care in Postural Management webinar. Our panelists today are Kirsty and Cutler, Anita, Joe McConnell, and Francis Kent. The first question is around equipment provision lists, which Joe, you spoke about a little bit in our part 1. Yes. How do you think that clinicians should acquire equipment outside their purchase list to ensure they get the best outcome for their service user?
Yeah, so this is a really important question, especially in today's climate where we're ever so budget conscious. So it's really making sure that that list really looks at all aspects, not just cost, because cost is obviously the one that is up there in everybody's minds. But when we're talking about skin protection, and obviously as we keep reminding ourselves that skin is the largest organ in the body, so it really deserves the same respect as every other organ in the body. So making sure that we're providing the most appropriate support surface, whether it be sitting or lying, for that individual. So making sure that on the equipment list, there is a range of options for a range of levels of need and risk. So we can't just look at every cushion as being equal or every mattress as being equal. Indeed, I work with seating and cushions and wheelchairs, so I don't really work with mattresses, but I know it's important to acknowledge both support surfaces. So if a clinician coming to the service with their client is raising issues regarding recurring pressure injuries, recurring pressure ulcers, and all of the cushions that have been offered are not really solving those issues, well, then it shouldn't be, well, actually, we've offered you everything on our list. It should never be that. It should be, let's go back to the root of the cause. So this is what we talked about a lot in the first session. So let's identify what's happening here. Why is there a recurring? What is the risk? What are the risks? And why is there a recurring pressure ulcer, pressure injury? And are we providing the correct support surface to deal with that, to protect this client long term? So we've looked at what we have on our list. We've looked at the choices that we've made clinically, but actually none of them are solving the problem. None of them are addressing the ongoing pressure injury. So yeah, it's really important that the clinician going to the appointment also feels that they are able to say, well, actually, we've tried all of these and none of them are working. And really every good wheelchair service or equipment loan store should have equipment in place to that's outside of their list also to look at these needs. So what support surface has been chosen? Is it foam? Is it gel? Is it air cell? Is it air? And what's working, what isn't working? So there's so much great information out there for clinicians. So it's about preparing when you go to an appointment, so you're asking the right questions, and also looking at manufacturers' websites, looking at what evidence they have in place, and looking what case stories they may have about what's worked for what client and why. So that's really important to always be prepared if you're the clinician going to an appointment, I would say.
How about you, Anita, and equipment lists? What's your experience with that?
Well, I think it's, I know we talked about this a lot in the last session as well. It's about understanding seating. It's about understanding postural management. And training is really, really important within all of this. You know, it's, and having your sound clinical reasoning as to why you've gone for product A or product B, and thinking outside of the box. We have some, you know, we do have cushions on our core equipment list, and we do have a budget for bespoke cushions, but it's about people's knowledge base, I think, and a lot of the prescribers will not have that knowledge base and will just go on to Google or the internet and just pick up equipment and then come to us and say, could we buy this? And we have lots of incidences where not so much now because we're quite strict on it, where they would buy a cushion and then they'd say, oh no, it doesn't meet the need. Can we go for another cushion? And really we have to balance those scales against the budget that we have and the equipment, the bespoke equipment. And we can't just say to people, well, sorry, this doesn't work, we need A, because that's people's money we're spending. So we are trying to get it into some sort of clarity. We're at the moment, we've just rewritten our clinical reasoning flow charts and also a clinical reasoning. But again, I feel sorry for the prescribers because yet other forms that they've got to fill in. So that's where we are at the moment. And everybody's busy.
Yeah.
How about you, Kirsty, when it comes to equipment lists? What's your experiences with the centre?
I think we are more, what I feel with my experience, we're luckier in wheelchair services than we are in other services, equipment services and or tissue viability services seem to be a little bit more restricted. So, you know, I think we do have a good education and training linked with our suppliers. We often have, you know, education and training through other groups, such as PMG and other organisations who will provide training around these issues around pressure care and tissue viability. So we are, in the service that I work in and the service that I have worked in, have been very lucky that we're not restricted to a particular equipment list. And that we, as Joe says, if we're finding that for some reason somebody's pressure injury is not healing in the way that we would expect, we would look at the whole regime of that person along with the tissue viability or district nurses, but then look to choose the most appropriate product. And if we're not sure what that product is, then a bit of peer support, a bit of peer training, look into the suppliers to provide some of that education and training as well to make sure we're looking at the right product for the problem that we see in front of us. But I you know, I'm very aware, and I've had personal experience that, you know, you talk to other services. I've started to have links with our own inpatient service, the tissue viability team in the main hospital trust, who, as I say, you know, had some cushions delivered and thought they would be okay. And I you know, I had to question that and say, well, yeah, but are they okay? Are they best value for money? Do they meet the requirements of the patients that you're seeing on the ward who you need to protect? You know, do they do that job well? Have you got enough of a range? Just because you know, they've chosen a particular dynamic cushion which works well and meets and matches the technical spec of their mattresses, it doesn't mean to say that the lower end of the scale cushions from the same manufacturer are going to be the right choice. So I do think we are a bit freer to make good choices with education and training behind us in the services that I've had experience from, and I hope Joe would think the same. I do feel that there may be more restrictions in other services and a little bit less clinical evidence behind the choices that are made.
Great. How about you, Frances? Do you have any comments when it comes to equipment lists?
Oh, I've always got plenty of comments on equipment. Me and Anita together. I think it's really difficult because I think every county manages tissue viability differently. Every acute sector manages it differently to the community side. So it depends where you are in the country and whether you're in hospital and whether you're in the community as to what those choices are. Certainly, I think in the acute, it's really difficult. Yes, and I do agree with they just order cushions and they're going to be okay. But I've certainly been involved where they've asked me about bedside chairs, and it's incredibly difficult because, that they're trying to meet the need of most people, but then look at the sizes of people that they've got, and then you've got to train the staff to actually go looking for the right chair if they have got a choice of chairs. So I think that creates a problem on the wards for a start. And of course, things go missing left, right and centre on the wards. That's the other problem. Certainly in our rehab units, we have got chairs in there from the companies that we use. And I have got the companies to actually swap some out sometimes when I've said, no, please don't do that chair. That's not one we're going to have in the community. And so they're getting better on the rehab wards of actually assessing people in the chairs that we would have out there that we supply. And of course, again, I think I probably said it last time when we did the Survey Monkey for the paper that we were doing, the guidance we were doing. And I've spoken to somebody recently who said they were absolutely amazed that in one county they didn't do chairs. And that's what we found. And how many years ago did we do that? That's got to be nearly 15 years ago that we did that guidance and found loads of companies either didn't do any chairs at all, or they had a certain amount of money that would only buy one chair, or they had to wait for the panel to sit. So that hasn't changed. It hasn't changed at all. I think the other thing is with the clinicians, we have quite a lot of choice on our community equipment core catalogue. There is quite a lot of choice, but I just this morning had an email about a client that they've been emailing me about, and the client will dictate what they're going to use. And we have got a situation at the moment where this chap is insisting he will sit in his in his kitchen on his kitchen chair, and the district nurse was really concerned. So I said, well, just get him to accept anything. Let's do a high back chair with one of our basic foam cushions on to just get him to do it. And he's declined it. He's now got a pressure ulcer. And what I've said to her is, can you get me the dimensions of the kitchen chair? And I will try and come up with something that might fit it. I don't know quite what I'm going to do, but I've got a couple of ideas. But I wouldn't expect the clinicians to have that kind of knowledge. And that's why I've got my job, why Anita's got her job. Those of us who are connected to the equipment services, that's what we do. We play the detective, and we know where to go to ask as well. I think that's the other thing. And with the networks we've got through, NAP, through National Back Exchange, Tissue Viability, we've got massive networks that we can actually send out to and say, has anybody come across this problem and can you help? So I do think that you can educate, but they've all got very specific jobs themselves. And the district nurses I couldn't do a district nurse's job. I wouldn't know where to start. And that's why we're employed, to actually help them out. So I think that how that is going to be resolved over the whole county. I just go back to 2000 when the Audit Commission audited all of the equipment services and came up with the words, they are like Cinderella services. And I think that we still are to a certain extent. I think that those higher up are not all recognising the importance of community equipment, because if you don't have a £15 commode, you can't get them home, or you've got to admit them. It's as simple as that sometimes. But I do think that there are other services that are more glamorous, and we still fall by the wayside because it isn't a glamorous service. But when, I don't know, have we spoken since our CEO came out with me? I can't remember. So he came out on visits, and I politically thought, oh, I know where I'm going to take him first. So I took him to the equipment service. So I took him to where I sit with my little office space and introduced him to customer service. And he looked at the warehouse there that was full of wheelchairs and continents. And then I took him up to the other two units, and they just had the biggest delivery of beds, you name it, and it was stuffed full. And I think his eyes were out on stalks, and he just kept taking pictures. And as we walked in, he said, but you've got another unit through there. I said, well, that was our first unit many, many, many years ago, before NRS. And then I walked him round, but he got it, because when we were out and about, and I took him out 3 different types of clients with chairs and problems and different diagnoses. And he said, but you must save the trust thousands. And I thought, he's got it. He's actually got it. And not everybody does. They just don't. And I think taking people around the equipment service, if you're trying to get any messages over, trying to get the importance of people understanding what they're ordering, people ordering correctly, people knowing what they're talking about, take them around the equipment service, because I think that is the biggest eye-opener. And especially when you've got wheelchairs, which we have got on our contract, wheelchairs are included. Because I think people just maybe think it's like a can of baked beans jumping off the shelf and it gets delivered, or, you know, somebody turns up the doorstep with a washing machine and you know exactly where the washing machine's going to go. Well, you turn up with the chair and it won't go through the door. Sorry, Francis, we can't deliver it. It won't go through the door. Well, can't you take the back off? Oh, I don't know how to. So, yeah, I think we've still got, we've got different problems that we had way back then. I think we've moved on in a lot of ways, but I think we've fallen by the wayside in others. And tissue viability is always going to be a massive issue, I think.
Thank you. And Kirsty, you had something you wanted to say as well?
Yeah, I was just going to mention that the difference between the acute side of things and community issues. The challenges that I've met really with dealing with our acute tissue viability team is the logistics and the operational side of what happens in the hospitals. You know, new hospitals, new buildings, no storage. They've thought about decontamination of all the things that are used in an acute way for all of those ward-based applications. But then when it comes to equipment for the ward, they haven't kind of thought about that as closely. So, you know, yes, I'll buy 15 cushions. Well, one, where am I going to store them? How do I decontaminate them? Who's going to decontaminate them? Who's going to make sure they are decontaminated? You know, these are real questions and really not being well managed, I feel, within the services that I've experienced. So try to, you know, there's also no joined up working, because the trusts and the organisations we work for are very separate in that. So I think there needs to be a little bit more discussion with who does those things well. How can I get a regular supply of decontaminated equipment for use on the ward? How does it get returned? How does it get issued? How can the nurses do that really quickly, because they're busy people and they have a really, really tough job to do at the moment. So I think there's a little bit of thinking around this aspect of what's used in an acute sector and what's used in the community sector, and how that can sort of work together. How can we use the best services? How can that operationally work much more smoothly? Because it's a real issue to get the right product for somebody in the hospital, and then how much money is wasted because that piece of equipment is then put in a skip because it can't be used for the next patient, but it could be if it was decontaminated in the right way. So you know, there's all those kind of questions as well that I think aren't really being addressed sometimes. So just a comment.
Yeah, thank you for that, Kirsty. And that's a really, it's a really good comment, because that's like leads us into our next question, which is for Anita, which is around how can you get all entities within healthcare, i.e. the acute, community, etc., to have a 24-hour approach to pressure management?
Well, I think both Kirsty and Francis has led into this really well in their comments, because the acute and the community, of getting them working together. It's about collaborative working, really, and also it's about the, for us, I've just sent a document to our acute hospital who are looking at mattresses, because they want to try and replicate the mattresses we have in community. So working in liaison with Francis, I've been able to send them the document, because that would enable that seamless care. But also we look at giving pins to so people in the acute sector can order equipment, but they can't order that equipment unless they've done the training. So that's my favorite word, you know, that training. It's always training. But so we in last year have introduced a new mattress. It's different from some of the mattresses we've had, and we have put a block on anybody that has not done the training on this particular mattress. They can't order it. And I think to date, since lockdown, I've now done nearly 1,000 prescribers via the internet, by Teams, because and I still block their pins. They are now, we've got a different way of training them now, but during lockdown, that's what we did. Because, you know, and it's that seamless transition then of the OTs in the acute sector, knowing what equipment we've got in our community equipment service, having access to that equipment and being then able to order that, because we can't be precious about, because I'm a nurse, you're an OT, you can't order health equipment or pressure care equipment. It's about that seamless journey for that individual from acute out into community, because the other problem we have within this transition of care and getting them out, once they've left hospital, nobody follows up with the equipment. And that again is the big problem. And, you know, and that is why I'm so keen that they know what mattress we've now got on our core list as well, because it does have to be set up in a special way. So for me, it's about getting collaborative meetings together. And when we're talking about this, I'm not just talking about the acute, I'm not just talking about community hospitals. What about care homes? Because care homes are really, really important in all of this, because in Berkshire, we do provide some equipment to care homes. Care homes should be fit for purpose, but there are times when there is bespoke chairs that need to go in. We've got to have our posture management chairs. We've got to have the tilting space, and care homes don't provide that. So it's about getting around a table and talking and saying, what are we going to do? Now, something like this document was done years ago. Francis and I did this, I can't remember, year 2000, I can't remember, Francis. Yeah, where we did what will go into care homes and what care homes will supply. And that has been updated, and a lot of unitaries, but we've still got a gap, and we still do have a huge tissue damage problem in care homes, without a doubt, because, you know, it's always this discussion, what equipment are we going to provide? Who's going to put it in? And then what the care homes buy. And it's about that good evaluation process, isn't it? Including all the multi-disciplinary, because what an OT needs from a piece of equipment, what a nurse needs, what a physio needs, are all different things. And they'll all come to the table with a different view. And that is where you get your multidisciplinary evaluations, and then you can then put the equipment in. I mean, I can go on for hours, but I'm going to stop now, because I'm sure there's other people who are itching to want to add to this.
Sorry about Anita. Francis, do you have anything you want to follow up with that?
Of course I do. With the tomorrow training, sorry, mentioning the mattress, sorry, I shouldn't have done that, but with the training, we've got the same mattress as Anita, and we've done lots of training. And what we find is that they forget. I go out time and time again and say, well, why don't you set it on this? And it's like, I'd forgotten that you could do that. The way that we got round the acute ordering the mattresses, because the acute sector, as they do in Berkshire, they have pins. Some of them have pins, mainly the OTs and some of the physios, not many of the nurses, have pins to order because the OTs tend to do the discharging equipment. But what we put in place was that when they discharge with any kind of mattress, especially the high-end, high-risk ones, is that they have to advise the district nurse teams wherever that patient happens to be going, and that district nurse team would be expected to go out and check that mattress within 24 hours. Okay, sometimes it's 48 because they just can't help, you know, the situations when they're suddenly short. But they have to go out and check that mattress, that it's on the right setting, it's actually working for the patient, and now they're at home. You know, everybody's different. They would have been on a different mattress in the hospital. So what they go on in the community and their compliance is going to be a little bit different. We do have compliance issues. So we've kind of got over it that way, but I do find that they just forget, you know, they've got so many other things they've got to remember. So I will do top-up training for them to just make sure that they are, you know, they're up to date. And if they say, I can't remember, I said, well, okay, get the team together and we do a short MST and I'll do some top-up training for you. Whenever I go out and there is one of these mattresses in place, then I will always go over it with the district nurses and the carers, and mostly say to the carers, it is a clinical decision what you set this on. It's not your decision what you're going to set this on. And if you've got a problem, get hold of the district nurses. But of course, some of the issues are that once the person has been discharged, if there is no need for a district nurse to go and do a visit, they don't go in unless a care agency rings them and says there's a problem, there's a red mark, or oh my goodness, there's more than a red mark. So the district nurses don't go and see every patient who is on a high-risk mattress or who is at risk, because their workload's massive. So they have to rely on the care agencies to let them know what's going on. With the care home issue, with the document that Anita was talking about, once we put it out there, we did actually look at updating it a few years later. But of course, once the ISIS team was dissolved, that it has never nationally been updated. But every county used that document, and every county, as far as I understand, and I see quite a lot of those documents, update their provision into care homes regularly. And they're kind of very similar, most of them. But at the end of it, there is a matrix of all the equipment that we've got in the equipment service. And alongside it says for care homes with nursing and those residential homes, so they're separate, what equipment we will supply and what we won't, but where we will support them with an assessment. And what we do is we go in and assess the client, because we get loads of referrals for seating and bed positioning. Actually, no, that's not true. We get loads for seating and go in and find out that they need bed positioning because they don't see that something can be done. So we will assess the client, and if we think it is not a complex need, but it is a safe seating with pressure reducing equipment or within the chair, what we will do is a report to that care home and say, this isn't a complex need where we would see that we would supply the chairs. You should have several of these chairs in the care home, and this is the chair we would advise. We're happy to come and do the assessment with the company, but you should be paying for it. Sometimes they have, and sometimes we suspect that they pass it on to the relative because they say they won't pay for it. They have all these beautiful chairs, and most of them are inappropriate for the residents that they have. The care homes, how we tackle care homes and postural and pressure care needs, I don't know. They tend to have the mattresses, but it's almost like you go into a care home, and if you start to develop contractures or whatever, well, that's what happens when you're elderly and you've got MS or Huntington's or whatever. That's what happens because they don't have the knowledge. And if you do teaching for those at the lower level, they don't have a way into the higher management. And even the manager of the floor and the manager of the home has to go to, if it's a big conglomerate, they have to go to the senior, if they do, to the owners of the companies. And of course, they go and buy from the specific companies that they want to buy from. So I don't know how we get over that at all.
Yeah. It is a very, very big question and a very big
Very
challenge.
sad. It's very, very sad.
Yeah. How about you, Kirsty? Do you have any comments to having more of a 24-hour approach when it comes to pressure care?
Probably from a slightly different angle is, I think that, well, not slightly different, but I think we all agree that it's the education of what 24-hour postural management means, so that, you know, and thinking about how within services, and that's not singular services, that's the, you know, collaboration between services, how that might be achieved. There are pockets of really good work within the UK where services have attempted to look at 24-hour postural management, so look at joined up assessments for individuals, and then access the equipment as they can, as it sort of is set up. There are also pockets of services where they've brought in additional services to, for example, in Gloucestershire, wheelchair services, where they've brought in a service for seating as well, for static seating as well. So, you know, that they have some of their staff that are trained up to do not just wheelchairs and pressure care, but then static seating as well as the wheelchair side of the seating. So I think there's a big issue for education and training of what we mean by 24-hour postural management. You know, we're talking about lying, sitting and standing. You know, we're talking about getting at people, individuals at an early stage, probably when they're paediatrics, and following that through. And we all know that there's a massive challenge in terms of the transitional phase between children and adults, where, you know, some services are great for children and young people, but then they tail off when they transfer over to adult services. So there's a number of challenges and barriers, but I think the key to a lot of it is collaboration in the educational stages and saying, okay, what are our challenges and barriers, and how can we, within our remit, overcome some of those, and, you know, thinking about what we actually mean by 24, you know, what is the definition of 24-hour postural management, because it will be different for different individuals and different services. So that's kind of how I would, you know, have just little thoughts around that, really. But I think it is a challenge, and one that I don't think we've managed particularly well at the minute.
No, I think that's absolutely great, Kirsty. Joe, I saw you having a little applause emoji. So what's your comment when it comes to 24?
Yeah, you're really relevant, everything that's been brought up today. It's great to discuss it with in this forum, but I'd like to say as well about 24-hour postural management that it's not just simply, like Kirsty says, breaking down into lying, standing, sitting. It's about how often are we varying the position in sitting as well, because somebody can be sitting for such a long time in the day, and their going to bed time can vary depending on their care setup and depending when that you know, home care may arrive to put them to bed. Could be really late, could be really early. So let's make sure that they're varying their position in sitting as well. And just simple things that should be happening that doesn't happen enough, which is when I do training and education in my role about air cell cushions, I'm amazed how many really experienced clinicians don't understand the importance of doing a simple hand check. So if somebody's posture's deteriorated throughout the day, so they're no longer sitting with a neutral posture, they're often sitting with a real posterior tilt. So where are they actually loading in sitting? So are the carers who are going in aware of doing this hand check? Do they know that they need to, you can do a hand check on whatever support surface you're sitting on. It doesn't have to be on air cell. You can do a hand check on foam, obviously, and that's the simplest, safest thing that we can be training people on, training family members on, training care workers on, support workers on. And do people really know what that hand check's for and why they're doing it? You know, that there's enough support surface between the lowest bony prominence and the seat base. And that's a really simple thing in 24-hour postural care that is missed an awful lot in sitting and in lying, I feel, and it's not talked about enough, the importance of the simple hand check. So sometimes we really, again, we've said this in the other session, we have to go right back to basics and never think something's too basic or too silly to mention, and just say, however embarrassed somebody might feel by it, say, Do you know how to do a hand check? Do you know what you're checking for? Do you understand what the risks are? What is the lowest bony prominence? Where is the likely to be the risk of a pressure injury occurring? And 9 out of 10 people won't even know what you're talking about, sadly. And this really alarms me in this day and age, with so many good education packages in place and so many things out there. We just need to take it right back to basics with 24-hour postural care as well.
Great, thank you so much, Jo. Diane, you had your hand up?
Yeah, thank you. Gosh, what a lot of really useful and important information in there. So I guess two sort of comments of things that maybe were always an issue, but maybe even more stressed now with the increasing workload and the backlog kind of reduction. And one that I see a lot, I think, is the review of equipment that might be suitable on discharge but isn't suitable for whatever reason, either deterioration or improvement. And I've seen spare rooms in people's homes stuffed full of community equipment, service equipment. So when is that review going to take place? Who's going to do it? Sort of reviewing up and reviewing down. And I think the other thing is looking at 24-hour posture management around sitting, lying, but also toileting, bathing, other areas where surfaces are involved. Sometimes with the client being involved with that surface for a considerable amount of time. And again, how does that fit into the overall kind of equipment provision, and who looks after it, who prescribes it, who maintains it? So just a couple of other thoughts there.
Great. And Frances?
Just to follow on from what Jo was saying about the hand checks, I think one of the problems is that as well, is that when we go out and we do postural chairs, most of them are hoisted, a lot are hoisted, not everybody, but especially with the hoisted clients that we see, is negotiating with the care staff. So always have the care staff and the supervisor, if possible, with you to discuss at which call they're going to get the person up when they first start sitting up. We've got so many who've been in beds for weeks and months and not got up. And you say they cannot be in bed. They can't be in bed all the time, but they can't sit all the time. And it's a real struggle because, first of all, I would only like them to be up for 2 hours, maximum of 3. That's almost impossible because, you've got to go with the times that they're going. And I can't remember who said about the problem with carers turning up late through no fault of their own. So it's actually looking at, well, if we get them up at this time, when can they go back to bed? And if people if they have QDS care, that's fine. Maybe that's easier to manage. But if it is, TDS 3 times a day, you've got long stretches in between the carers coming, and you also have to negotiate sometimes for a longer time for them to be there to actually hoist them up and into the chair. So the speed at which they do this and sit the person can also make the problem about how well they do position them in the chair, even after you've gone over it, even after you've gone over putting the sling on correctly, positioning them. So I think I said about it last time, is the reliance on carers is huge when we put this equipment in. And there comes a time when you have to withdraw. You can't keep going out to see those people. You have to withdraw. And back to clinicians identifying and not understanding is they'll tell you about a pressure ulcer that's developed, and you say, well, where is it? Can you absolutely describe? And they'll say it's, and you say, well, have you looked at how they're sitting? Have you looked at how they're lying? If you're telling me it's in that position, well, I suggest that they're not sitting straight in the chair, they're not sitting properly in or on the cushion. You need to go back and look at their seating position, but all they do is, there's a mark, there's a pressure ulcer, cushion must be wrong, mattress must be wrong, but they don't do the basic detective work about why.
Absolutely.
Can I?
Yeah, of course, Anita.
It's also about the interaction between pieces of equipment that you're using. So in chair slings, on rise recliner chairs or on your tilting space chairs, everybody likes in chair slings, and I understand why, but people do slide on them. So you have got that issue around shear and friction. So when you're looking at the chair that you're going to be putting in, does it work with the hoist? Does it work with the cushion that's in place? and does it work with the sling that's been applied? And that, I find, the combination of all these pieces of equipment working together can actually become a hazard rather than actually be beneficial to the individual. And that's what I really wanted to add there. So it's looking at that whole equipment provision and the whole system of what and provision of what you're doing.
Great, thanks so much, Anita. Final question for today is around standards. So Kirsty, what sort of standards and best practice guidelines exist within pressure care? And is there anyone particularly for postural management and pressure care?
I get the best question then. Now I have to profess I am not a tissue viability nurse, and I don't have a huge amount of expertise in this area. Jackie unfortunately can't be with us today, and she's obviously worked within and for a lot of these standards and guidelines. So I'm just going to give you a little bit of a nutshell, and then people can sort of talk about their own experiences. So within nursing and tissue viability services, there's a wealth of nursing care standards that can be used. So you've got obviously some international and European guidelines. There's the European Pressure Ulcer Advisory Panel guidelines, and that's a clinical practice guideline which was put together in 2019. Now they're not fully accessible on the internet. You have to pay a fee and get those guidelines, but are a clinical practice guideline that you can access. Now in the UK, obviously we have a set of guidelines, the NICE guidelines, which are a set of quality standards which include prevention, assessment and management of those with pressure ulcers. So the NICE website contains a lot of really, really useful information and service improvement tools. Now, for me, working in wheelchair and seating services, they're not particularly directed at our services or at equipment and community equipment services. So very much, again, nursing based standards and ways that nurses would assess and treat wounds. Okay, so, you know, looking and investigating things really before today, it's highlighted, you know, we all know that those exist, but actually what do they tell us? So within our NHS, and this is something that Jackie Fletcher certainly is and has been involved in the past, is the NHS Improvement Stop the Pressure campaign, and the standards and frameworks around that campaign. And this is almost an educational kind of curriculum, a training-based approach and model, but it is really useful for nurses and AHPs to look at how you would use a 5-step model for the assessment and management of those with pressure ulcers. But therapists in wheelchair services and equipment community-based services don't use these models purely in their entirety within those services. We might use certain bits of frameworks or bits of educational models, but we don't follow one particular way of assessment, of treatment, of choice of equipment within our services. This is why within the UK it becomes quite disparate, and why people are using different pieces of equipment in those services. So that leads me to kind of think about some questions within that, and it's about what models should be used. Can we modify those models for our services? But there's two main questions. How do we do that? And how do we use the work that's already there that we can develop into a way of useful wheelchairs and equipment services? And who, so the who bit, who should drive that work forwards? So, you know, it's great. We've got some good national groups that exist to do that. We've got some good networks that exist that could do that. But there really needs to be a focus and drive to say, well, these standards and guidelines exist. What's being used in really important services within tissue viability care and pressure ulcer management, and how can we develop those for use within the UK? And I think sort of thinking about today's webinar and investigating things, those two things came out for me. And maybe we're not as focused on that as we should be, really. So within services such as ours, we know the way we work, we know how we assess, we know we use pressure mapping, we know the choice of equipment we have. That's going to be different for a service that's very similar to ours in a different area. They will do this completely differently based on their own service culture and experiences within the team. And maybe we do need some standardisation across the board. So those two questions exist really. How do we do it using the existing guidelines, and who should drive that work forwards?
No, thank you, Kirsty, and thank you for all the research you put in ahead of the webinar. Joe, do you see a similar image as well in terms of, you know, there's not a standardized standard that's being used within healthcare?
Yeah, I would say so. And because I work a lot globally, I see real differences with the UK and other countries as well. And I'd certainly say that the UK seems to have, I'm talking from a wheelchair service point of view largely now rather than community equipment. I'd say there's such huge pressure on, and has been mentioned already, on budgets. There's always huge pressure on budgets, and then it's sometimes sadly driven down the quality of the provision. So it will be this, like we've said already earlier, it's public money. Everyone will always say it's public money, but I think we forget, and I know we forget, the cost of pressure ulcers. We have to keep coming back and reminding ourselves that if we just sometimes don't just reach for the foam cushions, and sometimes do look at providing earlier on, not too late in the day, really, when somebody's already on to a much higher category pressure injury, or then we'll introduce something higher, like ASL, higher risk. Actually, if we would have looked at their condition and their risks earlier, that we could have prevented that getting to that stage. So I think best practice has to be one of the standards that's always looked at, and looking at the wealth of evidence that's out there. Like we say, the Stop Pressure Ulcer campaign that's actually this month. It's a good time for us all to highlight in our workplaces with our colleagues how important this is. And yeah, looking at the guidelines that are there, relating it always back to the causes, back to posture, back to the condition, back to the home situation, and everyone together just doing their best to prevent this. It is a really joined up responsibility from wheelchair services, from community teams, from hospitals, and that's the only way we'll ever really get on top of it, is to all work together, and obviously working with manufacturers as well, asking them for advice, asking them for up-to-date education. And we can't do enough in this area, I don't feel. And it's sadly, it is what isn't one of the most glamorous services, as we've already said. It's often one of the things that's brushed under the carpet a little bit, and we can't leave people on bed rest for years hoping that these pressure injuries will just go away miraculously because they're on bed rest. They have to live their lives. They have to get back into daily life and be part of the, you know, out in their wheelchairs. So I do see it way too many times when people have got, you know, grade four pressure injuries, and it's a really sad situation to be working with somebody in that scenario. And I always think, how has it got to this stage? So we've got to always look at the evidence. We've got to look at just following our own best practices, like really good services do, like Kirsty in Bristol. You do a great job there. And like you say, sadly not all services do have as good a team behind them, or have a lot of staff shortages, have a lot of budgetary constraints. So it's a really tricky one, but us all getting together today is obviously part of us wanting to inform people and make changes.
Great, thank you. And how about you, Anita, when it comes to best practices and standards?
Wow, I think so much has been said by both Kirsty and Julie. Is it Julie?
Joe.
That I think I'm only just going to add two things, I think, really. One is that 24-hour postural management and pressure care is everybody's responsibility. It doesn't matter whether you work for social services or whether you work for health. And I think we need to come away from being task-orientated practitioners and back to holistic practitioners, where we go in and look at the individual holistically rather than just for the task. And I think that probably is I could carry on, but I'm not going to, because I think so much has already been said. So those are my two points that I would like to make.
Thank you, Anita. And finally, Francis, do you have anything you'd like to add with standards and best practices?
Not a lot, because I think it has all been said, but I can back to the differences in every county, because every tissue viability team is different, you know. In some counties where you've got separate community and acute trusts, they work in silos, so they work differently. We happen to be a joint trust, so the tissue viability team is one team, and they've you know, they've got one tissue viability nurse who concentrates on the community. But I do think it is, I think it is dependent on the number of people in that team. And I remember when, you know, tissue viability teams were first developed, and it was all about getting tissue viability teams together. They had big teams that, you know, how much a pressure ulcer cost going way back, you know, Pam Hibbs, you name it, everybody was quoted. And then a few years later, and they did a lot of training on the wards as well for key staff, but those key staff needed a leader to help them carry that forward. And then when these tissue viability nurses left, they weren't all replaced. So I'm sure some people can remember this. And so the tissue viability teams got smaller, and those people who were link nurses on the wards then didn't have anybody to lead them. And it comes back again to each trust being different and where the importance is seen, and making it really, really apparent that if we don't address these, then the cost is just going up again with the number of category 3 and 4 pressure ulcers and how much it costs in every single way, let alone the person's life and the family's life as well. I don't know how we get over that, because it seems to we go in great big cycles with these things. It's you know, it's a big focus and it's not a big focus, and then it's been infection control, hasn't it, for the last 2 years? Big focus on infection control, and they play a massive part in this as well. We can't take them out of the equation.
Definitely. Well, thank you so much, everyone, for all of your inputs. Diane, do you have any comments you'd like to say before we close the webinar?
No, just how informative it was, and how much I think there's some real common themes here about, you know, collaborative working and taking the silo thinking away, and also future-proofing decisions. So we're going to hopefully put prevention in rather than just treatment in terms of different aspects. And I just think there's some really key points here that could be raised higher up the the reaches of the NHS and social care, because it resonates, and, you know, there's a lot of very positive outcomes for clients there to be had, but also some massive cost savings, you know, so let's see what we can do to make that happen. But no, I'll just thank each and every one of you for such an enjoyable and informative session, so thank you.
And as with our part 1, we'll have a resource slide by the end, because Jackie Flett has been so kind ahead of the webinar to send us loads of resources that the audience can have a look on to learn more about the different best practices and standards within pressure care. So yeah, thank you again, everyone.
Thank you.
And that will be it.
Thank you.
Thank you.
Bye.
Thank you.
Thanks
Bye.
very much.
Bye.
Bye everyone.
Bye.
Thank you again for watching our webinar about pressure care in postural management. We hope it gave you some new perspectives and insights into the challenges in pressure care and how to solve them through more joined up thinking and a standardized approach. To sum up the key points from the webinar, when it comes to pressure care in postural management, it's important to have joined up thinking so that you're seeing the different parts involved in the patient's care, such as joint quotations and similar training for OTs, district nurses, etc. A key challenge is that there's a lack of evidence when it comes to choosing a lot of equipment. There's also a lack of generic guidance and standards when selecting equipment. There's a big focus on pressure ulcers and counting pressure ulcers, which can result in a lack of focus on preventing ulcers in the first place. Clinicians don't always have to go with what manufacturers recommend, but can be more inquisitive and ask questions about the equipment to ensure that it provides the best quality of care to the user. We hope that this is a step in the right direction toward understanding and integrating a more holistic approach to pressure care in postural management. We hope to inspire clinicians and the key decision makers to be empowered and make the necessary changes to improve our healthcare system. We are more than ready to include and gather more people and organizations in our movement towards a healthcare system where there'll be no harm and the best outcomes for patients are achieved. Thank you for your time.